Good afternoon. Today we're going to discuss the pulmonary function test. What is pulmonary function test? Basically, this testing provides a method for objectively assessing the function of the respiratory system. The tests do not always diagnose specific conditions, but should be used to gain a greater understanding of a patient's clinical problem. It identifies primary diseases of the respiratory system, such as obstructive versus restrictive or mixed disorders. It follows the course of specific disease over time, such as asthma or COPD. It quantifies the severity of the disease, assesses a response of a disease to a proper treatment, such as a bronchodilator. So you could do PFTs before and after bronchodilators. It does also provide exclusion of certain diseases processes from diagnostic considerations. For example, if you're suspecting upper airway obstruction, pulmonary function test could also be a useful diagnostic evaluation. Pulmonary function test must always be analyzed within the context of the patients being tested, because it depends on age, height, weight, race, and sex. It does directly affect the results because it is predicted based on that given individual and also based on parameters of a healthy individual within the same age. Diseases which the patient may have or drugs which they're taking may be important in the interpretation of the patient's test. For instance, in a patient taking medications for rheumatoid arthritis, the findings will be restrictive pulmonary disease, and the pulmonary function test will be interpreted as such. Or if the patient is asthmatic, will be obstructive. Let's review first, before we go into the interpretation of pulmonary function test, different lung volumes and capacities that you should remember from pathophysiology. There are 4 volumes and 4 capacities. What is tidal volume? Basically, is your normal breathing. Is the volume of air inspire and expire during a normal quiet breathing. What is inspiratory reserve volume? Is the maximum amount of air that can be inhaled after a normal tidal volume inspiration. So you inspire and expire normally with your regular breathing, and after a normal inspiration, you forcibly inspire. What is expiratory reserve volume? Is the maximum amount of air that can be exhaled from the resting expiratory level. So you inhale normally, you exhale normally, and after a normal exhalation, you forcibly exhale. What is residual volume? Well, after you maximally exhale or forcibly exhale from your regular expiration, whatever volume is remaining is your residual volume. So in other words, it's a volume of air remaining in the lungs at the end of a maximum expiration. What is vital capacity? Well, vital capacity is no more than the volume of air that can be exhaled from the lungs after a maximum inspiration. What is forced vital capacity? Well, you basically exhale forcefully from a vital capacity. What is slow vital capacity? You exhale slowly. Vital capacity is no more than the sum of inspiratory reserve volume, tidal volume, and expiratory residual volume. What is inspiratory capacity? Is the maximum amount of air that can be inhaled from an end of a tidal volume, and is no more than the sum of inspiratory reserve volume plus the tidal volume. What is functional residual capacity? Is the volume of air remaining in the lungs at the end of a tidal volume. Remember that for this force to be effective, it needs to have into account compliance and elasticity. What is total lung capacity? Total lung capacity is the volume of air in the lungs after a maximum inspiration. And as you could see, is the sum of all the volumes. Well, pulmonary function test basically evaluates one or more aspects of the respiratory system. It does evaluate lung volumes, airway function, and gas exchange. And the gas exchange will do it by the diffusion lung capacity of carbon monoxide. What are the indications for pulmonary function test? Well, it's a little obvious. It detects a disease, as we explained at the beginning. It differentiates between restrictive, obstructive, and mixed disorders. It does evaluate the extent and severity of the disease and also monitors the course of the disease. Evaluates the response to treatment, in this case bronchodilators. Measures the effect of exposures, because if a patient has been exposed to a toxic fume, such as in asthma, it does measure the effect of bronchoconstriction. It does also assess the risk for surgical procedures. Pulmonologists were often called for pre-op clearance on patients that have pulmonary disorders such as asthma, COPDs, bronchiectasis, etc. Many times, if we have time for the clearance, we indicate pulmonary function tests to assess the risk, mild, moderate to severe, in this patient before going to surgery. So basically, screens high-risk patients for surgical procedures, and even more on patients that are going for lung resection and lung transplantation, because you need to know exactly how much volume or capacity is still remaining when you're resecting one lobe or one lung. It does also provide occupational disability assessment. What are the contraindications for pulmonary function tests? Although not listed in the PowerPoint, let me mention them. If you have almost no volume because of severe bronchoconstriction, pulmonary function test is contraindicated during the acute phase of the disease. If you have a recent pneumothorax, if you have a recent myocardial infarction or unstable angina, if you have a recent chest, abdominal, or eye surgery, because you have to forcefully exhale, remember. So you're putting pressure in the intraocular space. What's the importance? Besides indications, patients and healthcare providers have inaccurate perception of severity of airflow obstruction and restriction. And it's very important to differentiate both, because not every single patient that comes in with shortness of breath is COPD. So you need to be able to diagnose not only clinically, but with the best evidence, which is pulmonary function test. It's the only diagnostic evaluations that could separate or exclude each other, obstruction versus restriction. So it does provide objective evidence in identifying patterns of the disease. What affects spirometry? Spirometry is affected by mechanical or resistive properties. What are the mechanical properties? Well, compliance. Remember that compliance describes the stiffness of the lung. If a patient has a very stiff lung, such as patients with pulmonary fibrosis, although you might get an idea from the volume loop that this is a restrictive disease, sometimes it's very difficult for the patient to finish the exam. Change in volume over the change in pressure, that's also compliance. Elastic recoil is the ability of the lung to return to its resting state. For example, patients with emphysema or patients with COPD would have low elasticity recoil. What are the resistive properties? Was basically determined by the caliper. The more bronchoconstriction, the more resistive to be able to finalize the exam. This is affected by low volume, bronchial smooth muscles. So again, severe bronchoconstriction would be very difficult to comply with this exam, although it's contraindicated. Airway collapsibility, patients having atelectasis would also have discrepancies during this exam. As we mentioned before, what affects the lung volume? Age, the sex, height and weight, race, and the proper disease, obstructive versus restrictive. Before we go into terminologies and analyze the actual pulmonary function test, I would like to go over with you with the most common disease processes that will give you obstruction versus restriction. Remember, obstruction is no more than, I want you to think about obstruction, any disease process that will give you bronchospasm, or any disease process that will give you secretions to the point of creating thickness and obstructing the expiratory force or the expiratory phase of respiration. In other words, bronchoconstriction, the best example will be asthma. Disease process that will give you elevated secretions to the point of obstructing the expiratory phase would be COPD. Why? Because COPD has chronic bronchitis as one of the components. And if you remember what's the concept of chronic bronchitis, is productive tenacious sputum for the past 3 months. So having high amounts of productive sputum could obstruct the expiratory phase of respiration. In addition to that, a mucus plug, bronchiectasis, patients with cystic fibrosis, all those are the best examples of obstructive pulmonary diseases. Restrictive pulmonary diseases, if you look at your body and you start from the outside to the inside, remember that the cage, the rib cage, also participates in ventilation. So if you have any type of deformity of your rib cage, that also will give you restriction to inspiration or expiration. Examples of those could be the pectus cabatum, the pectus carinatum, scoliosis, lordosis, kyphosis. So any rib cage orthopedic abnormalities would give you restriction in ventilation. Examples as well could be any trauma to the chest. Flail chest, for example, is a good example of restrictive disease, external. Broken rib. Now, if we come inside, what diseases could produce scarring tissue? Or if you are lacking one of the lobes or a whole lung, such as lobectomy or pneumonectomy, would give you restrictive diseases, internal. So what's the disease process that will give you plenty of scarring tissue? Pulmonary fibrosis. So pulmonary fibrosis will be one of the best examples for restrictive lung disease. All the autoimmune disorders that you already know, lupus, scleroderma, rheumatoid arthritis, patients with Sjogren disease, patients with sarcoidosis, that at the end will give you serositis, pleuritis, and pulmonary fibrosis, would be excellent examples of restrictive lung disease. So now that we know the difference between obstructive and restrictive, let's continue with what is the most important volumes to be able to interpret pulmonary function test. We discussed what is forced vital capacity. Remember, is the amount of air that you exhale after a normal expiration or after a resting state of expiration. When you forcibly expire, the first second is measured, and that is called forced expiratory volume in the first second. Then completely up to the end would be the forced vital capacity. So these two volumes, forced expiratory volume in 1 second and forced vital capacity, will be the two most important volumes to be able to analyze pulmonary function test. And even more, one of the most important parameters will be forced expiratory volume in 1 second. This would give you in detail the main difference between obstructive and restrictive. Why? Because the majority of forced vital capacity can be exhaled in the first 3 seconds in normal people, but often it's much more prolonged in obstructive pulmonary diseases. Remember that think about a patient with asthma. Patient with asthma has no problem in inspiration. The problem is when they try to expire, in the first second, they produce an alveolar collapse due to bronchospasm. So the FEV1 will be severely reduced and disproportionately reduced. Well, let's talk about normal parameters before we go to case studies. Forced vital capacity, normal is 80 to 100. And if you take 80 to 100 as the number for interpretation in almost all, you will be fine. There's a little difference between FEV1 and FEVC, but if you take 80 to 100 as your normal range, you will be able to interpret this. So normal 80 to 100, a mild reduction is 70 to 79, Moderate reduction will be 50 to 69, and severe reduction is less than 50%. So again, what is forced expiratory volume in the first second? Volume of air forcibly expire from full inflation, which is total lung capacity, in the first second. So it's no more when you tell the patient, take a deep breath, and now exhale as fast as you can. So when they're exhaling, you measure the first second. You could also measure a ratio or percentage 25 to 75, and then up to the end. Normal people, again, would do 80 to 100. I know here it says 75 to 80%, but I want you to remember 80 to 100 of their forced vital capacity. So the ratio is also important to be able to analyze restrictive versus obstructive. FEV1 again, normal is more than 75, so let's take 80 to 100 as normal. Mild is up to 75, moderate is 50 to 59, and severe is less than 49. But for your level, you're only responsible to interpret this is obstructive, this is restrictive. And what are the most common examples of disease process? Again, as I was telling you, you could measure at this level forced expiratory volume in the first second, and up to here 25 to 75%, which is the mean forced expiratory flow during the middle half. It reflects the effort independently, expiration, and the status of the small airways, but we're not going to discuss that. And these are the normal values. Now, the loops. There are different loops that also, if you don't have the numbers, which you would always do, but in case of an exam, again, not at your level, but for pulmonary, you could look at the numbers, and you could also look at the flow volume loop, because that would give you also an idea of what kind of disease do you have, obstructive or restrictive. If you look here, you have this phase is inspiration, and this phase is expiration. You inspire slowly, you never reach a plateau, and then you expire a little bit more forcefully. That's the normal volume loop. It does illustrate the maximum expiratory and inspiratory flow volume curves. And again, it's useful to distinguish between obstructive and restrictive. Talking about obstructive, an obstructive ventilatory defect is a disproportionate reduction of maximal airflow from the lung in relation to the maximal volume. It implies airway narrowing or bronchospasm during exhalation, and is defined as a reduced FEV1 VC ratio below the 5th percentile of the predictive value. In other words, it has the limitation of expiratory flow. And again, examples we already discussed, even though in your PowerPoint only has asthma and COPD. Remember, it could also be chronic bronchitis, even though it's a component of COPD. It could be a mucus plug, it could be bronchiectasis, it could be cystic fibrosis, etc. If you look at the loop, if you look at the normal loop before, now you look at the obstructive loop, you have basically a sharp, fast slow down in the slope of expiration. You have a normal inspiration, characteristically of bronchospasm. You have no problem in inspiration. You have the same exact normal loop, but then you have a high upstroke in expiration and a slow without ever reaching a plateau in expiration. Remember that patients with asthma, they would exhale the same amount they inhaled, but at a prolonged time. So they have a prolonged expiration. So if you analyze their volumes, they have low FEV1, so it will be less than 80, because remember, normal is 80 to 100. So the FEV1 will be low. The vital capacity would be low. And the FEV1, FEVC ratio will be severely low. Why? Because remember, everything that is impaired is at the level of expiration. So their forced expiratory volume in the first second will be severely impaired. Their forced expiratory volume in the first second ratio with the forced vital capacity, which is, remember, the end of that forced expiratory volume, will be severely impaired. So if you look at the numbers, FEV1 will be less than 80, VC or FEVC will be less than 80, and FEV1, FEVC ratio would be also less than 80, severely decreased. You will look at the examples later. Again, imagine this as being expiration. So you would have a slow rise in upstroke that never reaches a plateau, and a prolonged expiration. Restrictive, on the other side, is a defect characterized by a reduction in total lung capacity below the 5th percentile, but a normal FEV1 VC ratio. Why? Because either outside chest wall wise, or because of the parenchyma being so stiff and scarring like a pulmonary fibrosis, they would have a low inspiration and a low expiration. So when you do a ratio on those two volume numbers, the ratio would be normal, because whatever they take in, they take out. So that's the reason why the ratio would be normal. On the contrary, in obstructive, they take in or inspire a good amount, but when they take out in the first second will be severely reduced. That's the reason why the ratio will be disproportionately reduced compared to restrictive, which is normal. Examples of restrictive lung disease we already discussed. So any interstitial lung disease such as pulmonary fibrosis, scoliosis, or I forgot to mention muscular problems such as Guillain-Barré, muscular dystrophy, SLE, or Lou Gehrig's disease, myasthenia gravis, etc. And if you look at this, would be a rapid upstroke, and they would reach a plateau quickly. We can also diagnose large airway obstruction by looking at the loop. If you remember, this is the normal inspiration, but at the level of expiration, instead of doing this loop, which is in discontinued points, they would have a truncated loop. And this is very characteristic, either in expiration or in inspiration. A truncated loop will be pathognomonic of an obstructive airway disease by a foreign body or angioedema or epiglottitis, etc. So let's talk about examples. Let's look at this example. So what are the numbers that, forget about the loops right now because it will be difficult at your level. But if you look at the numbers, okay, let's look at the numbers. And remember, these are the numbers that you want to see because these are predictive values. So you would have it in decimal points or percentages. So if you look at these values, okay, let's talk about FEVC. FEVC is 110, which is completely normal, right? 80 to 100 is normal. So this 110 is normal. FEV1 is 80 to 100. 107 is normal. And the ratio, FEV1, FEVC ratio or percentage, is 97. So 80 to 100 is still normal. So this is a normal pulmonary function test. Let's look at case 2. You have FEVC, which is forced vital capacity. So your inspiration is 97. So inspiration is normal, but the forced expiratory volume in the first second, which is expiration, is severely decreased, which is 56. 80 to 100 is normal. And the ratio is also decreased. So it's in disproportion to inspiration. So you have here the best example of obstructive pulmonary disease. And if we need to pick up a disease process, example, asthma, COPD, chronic bronchitis, cystic fibrosis, etc. Now let's talk about this one. You have FEVC severely decreased, 34. So inspiration is low. Expiration in the first second is also severely low. But when you do a ratio, it's completely normal. Why? Because whatever you took in, you put out. It's more or less the same amount. So that's the reason why when you do a percentage math, it is completely normal. This is the best example for restrictive pulmonary disease. Examples could be a rib cage abnormality, or it could be a parenchymal interstitial lung disease such as pulmonary fibrosis. That's the best example, but it could be others. Another example, you have FEVC 69, FEV1 51, and FEV1 ratio is 75. Remember that for your exam, you might find a better number. Why? Because 75 is normal. Even though we memorized 80 to 100, remember if we go back to the prior parameters, will be normal. So to be basically clear, we could put here 80. So if you put here 80 because 75 is still normal, what do you think this disease process is related to? You have a low inspiration, you have a low expiration, and you have a normal ratio, although borderline. So this is again a restrictive pulmonary disease, but in more advanced cases. Another case. You have severely decreased, and severely decreased. This is most likely, what do you think? A mixture disorder. You have a mixed disorder here because if you look at the loop, which is not going to be in your exam because this is more for advanced, in pulmonology, in specialties. And also, I would have to add, no, I apologize. Let's talk about here first. This is no more than after bronchodilator therapy. So again, my apologies. Let's look at these values here, okay? So normal inspiration normal expiration, and also normal ratio. If you look at the numbers by itself, you might think this is a completely normal patient. But if you look at the loop, okay, you have a little bit more slow upstroke in inspiration and a long upstroke here in inspiration as well. And expiration, you have a prolonged expiration. So you do have a mixed disorder, but very, very mild. So this could be an initial presentation of a patient with a bronchospasm, okay? But what happens when you give a bronchodilator therapy? Because all this is as you could see, pre-medication, and pre-medication in percentages. So when you give a bronchodilator therapy, what happens? Let me explain how you best analyze also obstructive versus restrictive, although you see these parameters completely normal. So again, this is not going to be in your exam like this because this is a very complicated case. This is a mild obstructive pulmonary disease, an initial stage with an or underlying disorder as well that is giving me a mixed parameter. But let's concentrate here in the percentage of change after bronchodilator therapy. If you have a number pre-bronchodilator, pre-treatment, and a patient received the bronchodilator therapy, it is estimated that a 12% or more improvement after bronchodilator therapy of FEV1 is considered an obstructive pulmonary disease. So, for example, if I have an 87, if you have also the same predictive value here, if I give you here in this number instead of 38, I would give you, for example, 110. That is from 87 to 110 is more than 12% improvement. So in this spirometry is already giving you the actual percentage of improvement. So this patient after bronchodilator therapy improved 38%. And this is considered an obstructive pulmonary disease, mild initial with a mixed component because the patient improved from 87, 38%. So the number that should be here, if it's a predictive value instead of percentage of change, would be, for example, like 132, more or less. Okay? And thank you for your attendance. And I hope you could interpret pulmonary function test. If you have any question, you can also reach me at the office.